another case to work our way through here, and this is only painful, hopefully, for the patient in the case rather than everyone out here in the audience. So I promise you that. So we'll just start with this. This is AB, 66-year-old male with a past medical history of hypertension, type 2 diabetes. He comes to your clinic for follow-up. Doing well with his high blood pressure, doing pretty well with his diabetes. But he had a recent fasting lipid panel, which indicates he has hypercholesterolemia, and you start him on simvastatin 20 milligrams a day. It's what's on his insurance drug formulary. It's a very inexpensive agent, as you know, generic, so that's the one you reach for. At a later follow-up clinic visit, liver functions are doing fine, but the repeat lipid panel shows that his low-density lipoprotein, his LDL, is still not at target, and you increase his dose of simvastatin to 40 milligrams a day. Sounds reasonable, right? Okay, 2 weeks later. Patient calls your office, complains of muscle aches and pains. He thinks it's the flu, even though it's July, and he wants something to make him feel better, all right? So what would you do? Number one, it's probably the flu. Tell him to rest, increase his fluids, take some acetaminophen as needed. Write a prescription for some industrial strength ibuprofen. Tell him to stop taking the simvastatin and bring him back to your clinic for more testing, or none of the above. The favorite answer on all multiple choice tests. Yeah, there we go. Okay, yeah, put him on Cody. There we go. All right, 37. Wow. Tell him to stop taking the simvastatin and bring him back to your clinic for more testing. Very good. 97%. None of the above. That's always an option to do nothing. But clearly in this case, and since again it's the clinical pharmacogenomics, number 3 is probably the best answer. And yeah, that's the best one. All right. Yep. Okay, so he does exactly what you told him to do. He stops taking the simvastatin and promptly returns to your clinic. And he's still complaining about these muscle aches and pains. You get some labs here, and 140 sodium, potassium is 4.8, creatinine 1.2, BUN 15. You get a creatine kinase, or CK level, and it's 2400. And normal is this range here at the lab you use. Does that seem a little abnormal? Yeah, okay, good. So what is your diagnosis now? Not sure what anonymous means. I still think, number one, I still think it's the flu. This may be a myopathy from the simvastatin. I need more testing. 2 and 3, none of the above. And there we go. All right, we're closed. Okay. All right. Still think it's the flu. We didn't get any takers for that. That's good. Appreciate that. Number 2, this may be a myopathy from the simvastatin. Okay, you're thinking along the correct track there. Number 3, I need more testing. You can always order more tests. We have no limit to the tests available for patients. 2 and 3, a combination of potentially for myopathy and the need for more testing, and none of the above. And then this anonymous thing, I hope it's not that computer hacking group that's weighing in right now. But the answer here is 2 and 3, okay? And I'll explain to you why here in a bit as we get through here. But certainly this could be a myopathy. It's not the flu season. Started him on a simvastatin medication, which does, like all statins, has a risk for myopathy. And again, this is a clinical pharmacogenomic conference, all right? So you definitely want more testing too. So you're half right if you guess number 2, and you're the 3% that guess number 3. I'll give you points for that. You get partial credit, but 2 and 3 is the correct answer here. All right. Okay, and here we go. So you think it may be a statin-related myopathy from the simvastatin, and want more testing to confirm, but you aren't sure what to order. Okay, hopefully out in the audience you may have a good idea now, but you're here in clinic and you're scratching your head as to how to proceed. So I'm going to kind of revisit simvastatin in a little bit more detail, both its transport and metabolism. I touched on this a little bit in the first talk here, but let's delve into this a little bit more. Well, as I mentioned earlier, it's all about this OAT1B1 transporter, and this is coded by that SILCO1B1 gene, and again, it facilitates the uptake of statins. This transporter didn't evolve for statins. Our bodies are not that prescient, but it actually is a transporter for endogenous compounds such as bilirubin into the hepatocyte. And once it gets in there, it is metabolized by CYP3A4, 3A5. And the big issue here is changes in the activity of this transporter. And this can certainly increase the risk of severity of statin-related muscle damage. Okay? And a couple things can do this. It can be a simple drug interaction. So you always want to have this on your radar. There's quite a few medications that will inhibit CYP3A4. And cyclosporin is a big offender in this category. It also inhibits OAT1B1. And if you had a patient on simvastatin and cyclosporin, you can anticipate levels of the simvastatin to increase 3 to 8-fold, which is certainly not an inconsequential increase. But for this purpose of this talk, we're talking about the genetic aspects of this and the genetic variability in SILCO1B1, and specifically this one right here, this RS4140956, if you're keeping score, can also alter the plasma concentrations of statins. And it appears to be a simvastatin-related effect. Now, as we know, all the statins can cause myopathy. I'm not just picking on simvastatin here, but this particular transporter, this particular mutation here, seems to affect simvastatin more than the others. All right. So the nomenclature again. See, it comes back to haunt you yet one more time. SILCO1B1 star 1/*1. This is the wild type or the normal. It's also called the TT genotype. Unfortunately, most patients have this. So we're not playing too much of Russian roulette with simvastatin, fortunately. 55 to 88% have the TT genotype, and this is the high activity transporter. And we get into the opposite end of the spectrum, star 5, star 15, 16, and 17. These are the reduced functions, also called that C allele, and patients that are homozygous for this, and there's a number of permutations here that are possible, anything with any of these in combination. These have 2 reduced function alleles. This is the CC genotypes. In some studies, it can be, none of the patients have that, but it can be up to 6% of patients as well. And this is the low activity transporter. Fortunately, it's not that common, but it is the worst one to have of the 3 here. And then you have the heterozygous group. Again, this is the 1 functional and 1 reduced function allele. This is the TC genotype, kind of the mid-range as far as the distribution goes, 11 to 36% of patients. And this has intermediate activity. And if we go back to this study that I introduced earlier, and this was a study of 12,000 subjects taking simvastatin. The C allele was found to be associated with an increased risk of statin-induced myopathy. And the odds ratio for myopathy was 4.5 per copy of the C allele. So the more C alleles you have, the higher your odds for having a myopathy. Now again, the CC genotype, not a common one here. Most patients are the TT genotype, but still a fair number within this category here. Okay. Again, we have a very knowledgeable patient. He knows a little bit about genotyping. He agrees to be genotyped. He's not worried about the insurance ramifications downstream. And you discover that he has the CC genotype. Now, you still have the problem, this patient's hypercholesterolemia. So what do? He has the worst genotype for simvastatin. So what do? got a lot of risk factors for coronary artery disease. You want them on something. So number one, do you prescribe cholestyramine? Anybody know what cholestyramine is? Yeah. Do we use cholestyramine a lot? No. How come? Yeah, it tastes great, less filling. Yeah, it's not a very palatable compound. It will work. It's not as effective as statins anyway, but it's very unpalatable. I won't give that away, but you still may want to go with this. So you could pick number one, prescribe cholestyramine. Statins are just not worth the risk. Consult the CPIC guidelines for simvastatin. I'm still not convinced. I want a muscle biopsy, okay? Or again, none of the above. Let you think about that for a bit. All right. Okay. Some of you have never tasted cholestyramine. I'm going to say that much. Most of you, though, again, maybe it's a tip-off of a kind of conference or and we've talked a lot about CPIC, but you consult the CPIC guidelines for simvastatin. Fortunately, none of you picked another invasive procedure. I'm very happy with that, and none of the above, which again is always an answer, but the correct answer here is the CPIC guidelines. And fortunately, this clinical consortium has looked at simvastatin, and we'll talk about that next. But again, cholestyramine, not a great drug. All right. So here are the CPIC guidelines for simvastatin. I'll pop this up here. And I want to make this point again. I've said it probably more than once, is that these are the guidelines that also appear in that FDA-approved package insert. Okay? And I know it looks real busy. All right. But once you know their genotype, you can jump ahead on this flow chart. So it makes it a little easier. We know for a fact that our patient is this CC genotype, okay? And if you look across this little middle section here, again, this is the normals. So you can proceed based upon clinical risk, which is typical boilerplate medical advice there. Again, this is most of our patients, and most of patients handle simvastatin very well. And then when you get into the heterozygotes and the homozygotes, though, for the C allele, that's when you run into trouble. And the big warning here, genetic testing indicates this patient is at increased risk of myopathy with 40 milligrams of simvastatin, okay, which is what we prescribed our patients. So we're already in trouble here. And we know that he is the CC genotype because he can send it to testing here. So we've got a couple choices here. So once we get the fact that he's either heterozygous or homozygous, we kind of move on down here, and there are a couple choices. We can either lower the dose. We can go back to 20 milligrams on this patient and monitor serial CK, consider a lipid clinic. I don't know, what are some pitfalls for this specific patient in going that route? Exactly, yeah. Exactly. So we already know that his 20 milligrams just was not clinically effective. Sometimes when patients get prescribed a simvastatin, they think that's kind of insurance so they can still eat the way they did before. But as we all know, it's diet and statins and all that. But and also monitoring serial CK levels, it's certainly a reasonable thing to do. It does require a lot more work, a lot more cost and expense. And we already know that this gentleman had a bump in his CK already. So again, I think this is a less desirable one. Primarily for he didn't respond well to the 20s. We know he'll bump his CK anyway, and it's just a lot of work and a lot of expense. Because fortunately we have an option 2, which is the alternative statins, and there's choice 1, 2, and 3, and these are 3 choices here. Now, the caveat here is that each one of these can cause myopathy by itself. So these are not, the safe agents. They still carry that risk. But based on this patient's genotype of the CC here, these are safer agents. Again, simvastatin, at least the clinical data we have so far, the SOCO 1B1 variant that I mentioned seems to be more of a problem for the simvastatin than these. Now, that doesn't mean, and as Dr. Flockhart mentioned with codeine, that simvastatin is a bad drug. Again, let's put this in let's have some perspective here. Most patients are this TT genotype here. So it's still a good drug. It's very inexpensive. It's probably on every insurance company's drug formulary. So it's still a very reasonable choice, but it does have this risk. And so here are some options, which I'm not sure the generic status of all these. Torvastatin, that's generic now. Is that correct? Yeah. Rosuvastatin. Nope. How about pravastatin? Okay, all right. So if cost is a consideration, which it always is, there are some options there. All right, here is the epilogue. Currently, clinical screening for SILCO 1B1, despite this data and literature, is still limited, and it's largely confined to research studies, certainly at this point. More data is coming out. It is for those academic centers across the country. For many of them, it is part of the genotypes that they screen for. So it is emerging. But again, I can't stress this enough. The dosing algorithm is in the package insert. You know, what obligation do we have as clinicians to pay attention to that package insert? I don't know. But it certainly suggests regulatory acceptance, obviously. And again, the CPIC and FDA work hand in hand. So if the FDA likes it, so I think it's only a matter of time before SILCO, simvastatin, and other medications are used. I think we're going to see a broader clinical application of this pharmacogenotyping. All right, very good job, and everyone gets A's today. Any questions?